Okay, so let's take a look at another important topic of pediatrics, that is epilepsy, and what are the important points regarding epilepsy that you need to know for attempting SEQ questions of a pediatric exam. So first of all, what you need to know is that for a generalized tonic-clonic seizures, which are also called as grand mal seizures, there are certain phases. There is a tonic phase, a clonic phase, and a post-ictal phase. There are three phases of generalized tonic-clonic seizures or grand mal seizures. In the tonic phase, there will be contraction of the muscles throughout the body, which will lead to loud moan or ictal cry in the child, cyanosis, tongue biting, etc. So contraction of the muscles throughout the body will be seen in a tonic phase. Then clonic phase, and what is seen in clonic phase, there will be a superimposed relaxation. So in tonic phase there is contraction of muscles, and in clonic phase there is a superimposed relaxation of muscles. And what makes the post-ictal phase, there will be unresponsiveness in the child, muscle flaccidity, excessive salivation, incontinence. Patient regains consciousness over minutes to hours, and the patient may also go into sleep. So unresponsiveness, muscle flaccidity, excessive salivation, incontinence, patient regains consciousness over minutes to hours. These are the important components of post-ictal phase. So tonic phase, clonic phase, and post-ictal phase, these are the components of generalized tonic-clonic seizures. Now what constitutes absence seizures or petit mal seizures? So these are very brief episodes. There is no history of fall and jerky movements or bowel and bladder incontinence, and there is no post-ictal phase. So there is no loss of consciousness, there is no seizure activity. The child just loses consciousness in such a way that he does not fall. His muscle tone is maintained, but he is not aware of his surroundings and he seems to be lost somewhere. Okay, now what is the prognosis of absence seizures or petit mal seizures? So 80% of children respond to medications and there is a good remission rate, and 40% of children may develop generalized tonic-clonic seizures in later life. Okay, now what are the important investigations that you can carry out in a child having epilepsy? There can be neuroimaging like CT and MRI to rule out any organic brain disease or any underlying pathology in the brain. Then we can do a 12-lead ECG to rule out any source of emboli due to atrial fibrillation, etc. And electroencephalography or EEG is the investigation of choice for identifying or you can say diagnosing epilepsy. And the findings, the possible findings which you can see in an EEG, these include okay, first of all, during rest, the EEG is normal. EEG is normal during rest, and what you can observe is you can observe a 3 per second spike pattern during attack. So at rest the EEG is normal, but when you do an EEG while the patient is having seizures, you can find a 3 per second spike wave pattern, okay, during attack. So this is what you need to know about the findings on EEG in case of epilepsy. Okay, now how will you treat a case of epilepsy? There are some principles of anticonvulsant therapy. First of all, long-term anti-epileptic drugs are given after second attack. After first attack, we do not give long-term anti-epileptic therapy. It is given after second attack. And we need to start all drugs in low dose, increase gradually to full dose till seizure control is achieved or the side effects start appearing. So we have to increase the dose to such an extent that no side effects should be seen. And once side effects start appearing, we need to stop increasing the dose of drug, and we need to maintain an adequate dose such that the seizures are controlled and also no side effects are seen in the patient. And also prefer extended release formulations so that repeated dosing is not required. And if no control is achieved after maximum dose of first drug, then you can add on a second first line drug, anti-epileptic drug, and taper the. Okay, so what we're going to be doing is that if first drug is not able to control the seizures, then we can add on a second drug while the first drug is already given to the child, and then we can slowly taper off the first drug if the seizures are controlled on the second first line anti-epileptic drug. So if the seizures are still partially controlled, then you can add a second AED as add-on. So you can give two drugs at the same time if the second drug is required and one drug is not enough for controlling the seizures. And you can use rational polytherapy as far as possible. And valproate and carbamazepine are better tolerated as first line drugs. So what are the first line anti-epileptic drugs? These are the valproate, sodium valproate, and carbamazepine. So the principles are such that first of all we'll try to use the minimum possible dose of anti-epileptic, then we will increase it gradually to such a point that the seizures are controlled and side effects are not there. And then we'll prefer extended release formulations, and if one drug is not able to control the seizures, then you add a second drug and then slowly taper off the first drug. And then if one drug is only partially controlling the seizures, then you can add another drug and keep polytherapy. And the first line drugs are valproate and carbamazepine. Now, what is status epilepticus? When multiple episodes of fits occur without regaining consciousness in a short time duration, and this time duration is 5 minutes. So if within 5 minutes the seizure activity does not stop and multiple episodes occur without regaining consciousness, that is called as status epilepticus, and it occurs in an epileptic patient. Now, what is the ER management of status epilepticus? So initial therapy will include the general measures. For example, will ensure airway patency and give oxygen inhalation to the patient, will monitor vitals and secure IV access, will send blood for investigations, for example CBC, coagulation study, glucose, urea electrolytes, LFTs, anti-epileptic drug levels in the blood, that if there are adequate levels or not. So we'll do the remaining examinations to identify any other cause of seizures, for example hypoglycemia, hypocalcemia, or deranged LFTs, or deranged renal function. So these other investigations should also be carried out as part of routine examination in a seizing patient. So, and very important in this case is the anti-epileptic drug levels, because mostly status epilepticus occurs when patients you can say forget to take their regular dose of anti-epileptic drug. So these are the initial therapy options. Then if the seizures keep occurring for more than 5 minutes, then you can give midazolam or lorazepam or diazepam and repeat once only after 15 minutes. So first line anti-epileptics for status epilepticus are midazolam, lorazepam, diazepam, and repeat only after 15 minutes, and these are the benzodiazepines. So you can also correct the metabolic triggers which cause the status epilepticus, for example hypoglycemia. That is why we'll check the blood sugar level as well in these patients. And ongoing therapy will include, if these were the protocols for seizures more than 5 minutes, but if the seizures are occurring for more than 30 minutes, then you will give IV phenytoin or sodium valproate or phenobarbital. And along with that, we'll do cardiac monitoring and pulse oximetry, monitor the neurological condition, the blood pressure, respiration, and ABGs. So if the seizures continue after 30 to 60 minutes, then transfer to ICU. Start treatment for refractory status with intubation, ventilation, and general anesthesia using propofol or thiopental. And EEG monitoring should also be continued. Once status epilepticus is controlled, then long-term anti-epileptic therapy should be done with sodium valproate or phenytoin or carbamazepine, and investigate the cause for status epilepticus as well. And the long-term management is such that avoid the risk factors. Anticonvulsant therapy according to the type of epilepsy, psychological intervention may be required, and routine vitamin supplementation and regular exercise should be advised in such patient. So these were the important management protocol for status epilepticus, and these include initial therapy of general measures, ensure airway patency, oxygen inhalation, vital sign monitoring, securing IV line, and sending the basic blood examinations. And others are the if seizures occur for more than 5 minutes, then we'll give midazolam, lorazepam, diazepam, and repeat only after 15 minutes. And correction of metabolic triggers, ongoing therapy will include, if seizures are occurring for more than 30 minutes, then we'll give IV phenytoin or sodium valproate or phenobarbital. Cardiac monitoring and pulse oximetry will be done, and neurological condition will be monitored, and also BP, respiration, and ABGs. Seizures if continued after 30 to 60 minutes, then you have to transfer to ICU. And seizures if continue after 30 to 60 minutes, then you have to transfer to ICU and start treatment for refractory status with intubation, ventilation, and general anesthesia using propofol and thiopental. And then we'll do EEG monitoring, and once status epilepticus is controlled, then long-term anti-epileptic therapy will be provided with sodium valproate or phenytoin or carbamazepine, and investigate the underlying cause. And long-term management will be such that avoid risk factors. Anticonvulsant therapy according to type of epilepsy will be given. Psychological intervention may be required, and routine vitamin supplementation along with regular exercise. So yeah, that was important points regarding epilepsy, and I hope it was helpful for you guys. Thank you so much for watching.